growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, I'm Dr. Steve Rasner and welcome to The Lionhearted Dentist. Last week we were speaking about the importance in case presentation of one model. And by the way, before I forget, at one point I said, look, if you can't find this model, it was in a maxillary edentulous and a mandibular edentulous articulated model with the dentures. So you could take the dentures off and evaluate what's really holding these prostheses in place. And of course you can separate the articular between the maxillary and the mandible, and even take the models off and show patients right in their hands. And I only focused on the maxilla last podcast. And today I want to talk about how the mandibular model has even a more powerful effect. And I mentioned at one point, and to be honest with you, I haven't tried this, but if any of you wanted to get a duplicate of my models, I mean, beautiful, you'd have to articulate them on your own articulator, of course, but the models themselves would be impeccable. I'll try this if one of you requests such, and my email is my name, drrasner@aol.com. There'd be some fee for that. I don't even know if it's something I want to do. I just mentioned it, so I'm following it up. You can certainly have your own, and I talked about that, of how to do that. But it's a powerful, powerful tool in the communication we have with our patients. And, you know, case acceptance is all about that patient in your chair visualizing and understanding the potential, what you might offer them and what they would end up with. And certainly 3D models are a powerful tool with that. Today I'm going to talk about the mandibular model of that and how that influences treatment as well. I do want to mention before I get into that, last week, and this is self-promotion, but I don't care because it's an amazing event, we had our rescheduled live implant training course with doctors from around the country. We had it originally scheduled in March of this year, but of course the pandemic canceled that. And so we were able to re-up it and did it last weekend. And I got to tell you, for those of you that are trained didactically or have minimal training in implant surgical dentistry, it was my first true course dedicated just to that. Because I generally give courses in my office on atraumatic extractions and bone site development, grafting. And on occasion, if the attendee had a lot of experience, we would throw in some implants as well. And so this is my first dedicated one to implants. And so remember, those of you that don't know this, I have a course, and if you have a license anywhere in the United States, you can actually practice for 2 days live in my office based on an agreement that I secured with the state of New Jersey a couple years back. We did, I don't know, to me it sounds like a lot, 19 surgeries over 2 days between 6 doctors. Everything from immediate extraction and freehand placement to full flap, full bone reduction guide, guided implant placement. And I had, for the first time ever in my teaching in my office, I had significant help in teaching. I had a periodontist there to help doctors with flaps and certainly suturing. And I had another couple experienced guys in implant surgery. So there was massive one-to-one instruction. I mean, almost one-to-one. And of course, I floated the entire course and often jumped in. But these are courses that I think are absolutely necessary. Whether you take it with me or somebody else, and there's just not that many options, live, hands-on, to get some wet hand finger dentistry under your belt with the security that we're right there, I'm right there. And we don't just throw you into a room. The case has been talked about before you ever go in there. So look, I know there's a big leap for all of us from taking the Mish Institute for 9 months or a Maxi course for a year. And now what do you do? And so, look, I'm proud of it. It was an enormous amount of work, enormous amount of planning. All the patients were hand selected, of course, by me. I tried to get mostly ASA 1s. I'm not sure how that worked out. Patients that are basically healthy. But it was a fabulous experience, I can tell you firsthand from the reactions I got from the docs. You can reach to Beth, whose email is available to all of you, and I just gave you my email, for our 2021 dates. We're going to break it down into two this time. One, I wouldn't call it a beginner's course, but an easier level. I don't want to underestimate the importance of that. That's the kind of stuff that comes in your office every week. A root canal tooth broken off at the gingival margin or below in a very easy area, a premolar, a lateral, cases like that. Maybe a simple case between the mental foramen. And I think we are going to separate full arch cases, full extractions, followed by a bone reduction guide, followed by implant placement, followed by grafting. I think that should be its own course, along with auxiliary procedures that may be required, sinus lifts and stuff like that. So we're going to have 2-level courses. And along with my extraction courses as well, which we still are giving. I got one that's sold out in 3 weeks from today. And that's learning how to take teeth out atraumatically and site development, grafting. And that's a loaded course as well. And they're live. You're doing the surgeries. So yes, I'm using the beginning of this podcast to mention those because I think they're worthy. Okay. And that said, I want to tell you something. You know, from time to time in the last couple months, I like to look at my schedules because I can't remember this by myself and see where my productivity, that we all want to be productive, came from. And I try to remember to bring my days home because I do these podcasts usually on the weekend. And this is from this past Thursday. The first thing I want to point out, it was another very good week for me. And what I mean by that is rarely do we have cancellations. So I had very productive time of my time being in the office, doing challenging procedures, getting paid and not worrying if I was going to get paid for that, not accepting reduced insurance payments, all of that to me, and not working my brains off either, to be honest with you. I mean, going in and beginning patients on an average of somewhere between 9 and being done by 4:30. It wasn't always like that for me. I paid some dues, and I know a lot of you are paying dues right now. But if I look at the schedule, and I think this applies to almost any schedules that I would pull from a given week, the schedule in terms of having implants or oral sedation or surgery, like removing teeth, has to be about 70%. Now, some of these are just restorative at this point, but they were implant restorative cases. And they all come from the basis of having an oral sedation permit. And I just got to tell you that I wouldn't be talking to you right now. I wouldn't have the practice I have, in my opinion, if I didn't acquire the skill sets of oral sedation, removal of teeth atraumatically, the ability to graft and grow bone, implant surgery, and the concomitant prosthetics. It is what I do. Now, could you do that with other skills? Spinning off of the basis of having an oral sedation availability for your patients. I mean, I can't speak to detail because I don't have that kind of practice, but like if I couldn't do this, what would I do next? I would become amazing, I hope, at endodontics. And I would do with endo what I did with oral surgery. I would be relentless in my pursuit. I would take opposing points of view or different points of view clinically. I would take hands-on models. And I know there's tons of guys that I don't pay that much attention to, Cliff Ruddles or the people I've seen over the years in journals that teach. And I would get a microscope, just like I have a CBCT. And I certainly remember a time where I never thought I would own a CBCT. And now, and when I took it, I don't think it was a thing dentists bought so much for endo, but now I know it is. And so it sure as heck feels like becoming the standard of high-end dentistry. I think you could spin off this into a multitude of other skills, even if you didn't do surgery. And I just can't repeat to you enough that it's the basis of me staying busy is the bottom line. And it has different requirements in each state. And look, I don't know if it'll be forever. I understand that there's a component of oral surgeons that are trying to stop that from happening in a lot of states. And if having an IV sedation license was a requirement to provide oral sedation I'm providing, I would get it. I've thought of getting one anyway. We all have different philosophies of what we're comfortable with and how we practice. You know, I've always, when we'd be doing oral sedation, we would bring in an oral sedation doctor to provide that for us. Even if I was going to do oral sedation and I had to get an IV license, that's what I would do. So let me get to the lower model. Don't poo-poo this. Don't turn this off. Listen to me. I thought about this before I decided to share it with you. You know, I tried to think, what are the things, if you were with me one-on-one, I could give you right away to have the greatest impact on the greatest influencer in what you do each day, which is case presentation, right? You get to a point in your daily practice or during the week where somebody comes to you and your job is to communicate what it is you think they need. And I am here to tell you that over my career, I bought videos. I remember spending $2,000 once in a Canadian-based company, I can't remember the name of it, were these amazing graphics and videos that you would put in front of the patient to explain crown and bridge, root canal, implant dentistry, the lack of replacing a tooth. And what's lost in that is you, which is huge. What's lost in that is the person-to-person communication, the personality that you have, the passion you have. So I use 3D models to an extreme. And if you don't know what I'm talking about, if you skipped a couple podcasts, I tuned in last week and told you this. I think when I originally started to use these models, it was strictly for the terminal dentition patients that came in that were going to lose all their teeth in their mind. By the way, that's a common thing I ask when I'm with a patient that has a debilitated dentition, but it's not a foregone conclusion that they're going to lose all their teeth. You know, I'm not talking about a case type 4 perio patient that's done. I'll ask them often, let me ask you something. In your mind, before you got here, and you were thinking, I'm going to go to the dentist, what were you thinking about your whole dental situation? Where, you know, I tell them I've been in this a long time. There's people that come in here and say, my parents had dentures. I know that my time has come, or something like that. Or I know I'm going to lose. That you're going to tell me I'm going to lose all my teeth. Because it helps me get a framework for what they want. Sometimes they're not even close to losing all their teeth. And that becomes a very positive conversation. And of course, sometimes they're right. They're dead on. Most of the time, they're not right. But I use these models to promote the importance of never getting near the decision tree of, do I need now to take all my teeth out? And unless it's a foregone conclusion, class 3 mobilities, purulence, 75% bone loss, malocclusion, spleen, and all that, unless it's that, and often it is not even close to that, I am joyful to tell this patient, well, let me slow down for a minute. First, let me tell you what it's like to have a denture. And I'll say and I'm not scaring you, I'm going to assume that most patients don't really know. Yeah, you've seen your friend or your grandfather's denture, but you may have never held a denture up close in your hand to understand what it is you're actually thinking of getting. And I want you to know that now, and I want you to know the details about it. So I'll hold a model of an edentulous maxilla that the denture in your hand belongs to. And I'll say, look, in a lot of people, we're able to get a seal here that allows the denture to be retained by you, certainly to an adequate degree for most patients. That said, there's some things about this that I want you to witness. I want you to take note of. And I'll always point out the roof of the mouth. And I'll point out the lack of pounds per square inch of function with a full prosthesis versus what? Because I'll say something like this. I'll say, even with your teeth, as sometimes I'll say beat up. Sometimes I'll say debilitated, as they are. I promise you, you'll eat better, meaning tear food off, with the teeth in your mouth than you will with any denture I make you, if that is in fact true. I mean, depending on what kind of dentition they have. I'll say things like that. See, it's not a scripted thing. This is all coming from my heart, from my passion of what we do, what you do each day, what I do each day, what my knowledge and experience is. Sure, do I have a lot of patients that accommodate to a full upper denture like you do? Yeah, I do. Would some of those patients have been better served, even if it was for 5 years? 5 years is 5 years. With maybe a partial prosthesis? I think so. And I know some of you that are saying, well, why not just put them into an implant hybrid? Well, I'm in a community, number one, where there's just not a plethora of patients able to afford that. And by the way, I still think their own teeth, if they're functional and maintainable to any degree. Now that's a loaded statement because that means I'm assuming, I tell the patient that they're going to be compliant. I tell them that. And I have a lot of patients sit in this chair that nod at me when I tell them they have to come in every 3 months and then I don't see them for 2 years. And when they come back in 2 years, they'll say, I know you told me, but that doesn't do me any good because in my heart, I don't want them to have a full upper denture. And I certainly don't want them to have a full lower denture. And now I'll take the lower model out and I'll say, the biggest difference between these two models is what belongs right here on this lower, and that's called your tongue. And they get it. When you swallow, when you speak, when you yawn, there's muscles attached to your tongue that pop a full denture out. It is a curse, in my opinion, for most patients. So where does that leave me? It leaves me with if that is your only financial choice, then I will do everything possible to give you a treatment plan that maintains a number of teeth, if that's possible, 4, 3 at sometimes I've done. If I can maintain these for whatever years I can. Now, I'm not going to put them in a treatment plan that I believe is going to last 18 months. If I believe from my experience, we're not talking about 3 mobilities on a scale of 1 to 3. We're talking about, for whatever reason, we all know periodontal disease is site-specific. that they have a few teeth that could be, they may not be beauties, but they can't afford an implant prosthesis. And the option is a full lower denture. It is just a rare thing for me. That said, I had an 80-year-old just 3 weeks ago who's been wearing a full lower for years. And that's a different conversation for me and you. And because they usually happen like this. She just had one made by a chain, and she's blaming them for the poor quality, is what she said. And so my approach to that patient is, the problem is would it make a difference if I assembled the greatest impression takers and teeth makers of lower dentures in this office for a week to work on your denture? Would it make a difference? It might make a little difference. But the problem is that the best denture most patients ever get, particularly on the lower, is the first one. And over the years, as we all know, the bone resorbs. So now we're 15 or 20 years into this process for you. And here's the truth. The only thing that would be palpably different for you would be an implant retained. And I take no joy in telling you that. You're 80 years old. I say it just like that. I said, but this is what I know about 80-year-olds. You're all completely different. Some of you are in government, and we see you on television every day. Others of you ride bikes 5 days a week or play tennis. And we both know that there's people much younger than 80 that are halfway in the ground. Or what, I maybe not say that, but I'll say something, that don't live a very full life. So it's a completely your decision. And of course, besides going through the procedures to get to that end, there's cost involved, and significant cost. So it's a really up to you decision. My job is to make you crystal clear, not look at you and assume you wouldn't have a denture. You have no medical compromises or comorbidities. I found that out already. So yes, is it something for you to go through? Absolutely. And my go-to case on many of those patients is 3 implants, a bar, and the bar may have O-ring retainers or may have zest locators or hater clips or whatever I think is appropriate. And that patient is having that done. And that just rolls off my cerebellum because it's what we do. It's what I do all the time. Even if you didn't do the surgery, you could have that conversation. If I didn't do the surgery, then I would absolutely know the cost that my surgeon's going to charge for this in a range, or I would know it cold. I would know this. I would have this conversation with my surgeon because I think it's a really bad and negative case acceptance approach to have them then go to the surgeon, get their cost, then come back and get the prosthetic cost, which is again why I encourage my colleagues who have such a desire to train and be able to do the things I'm telling you about. So that's what I have for you this week. I mean, I'm trying to communicate to you guys. To me, it's so basic at this point. Granted, I've been doing implants for 25 years. But I have cases that go back 24, 23 years that are bar retained cases. Now, I didn't do them my first 6 months out. And the training availability to you is greater than it's ever been. You got to decide how bad you want it. I said this last week. You don't have the right to complain about the status of your profession or your particular practice or even your income if you're not doing anything about it. It's right in front of you. Physicians don't have the ability to change their skill set as quickly as you and I do. They don't. How bad you want it? There's a guy on Facebook, he doesn't even know I'm mentioning him, that went back to perio school. I think he's 55. He may be the oldest periodontal student in the history of perio. That's how bad that guy wanted what he wanted. And look, sometimes you put your little pinky in the water and you don't like it. That's okay too. But I'm here to tell you that there are a number of routes. The route I've told you too many times, you know the route. Oral sedation, atraumatic extractions, on and on. I think that's the easiest way to have a fulfilling career in dentistry. But even if I didn't do all that stuff, or you, it starts to me with an oral sedation permit, because that attracts patients in every community, in every city or country or rural area in the world. And it's not just giving somebody Valium. You have to be trained. You know, again, those of you who may be new to me, I have an amazing protocol that puts patients, it couldn't put them any more perfect. Doesn't work on 100%, but it's damn close. All right, guys, this has been fun for me. I hope you're having a great week. I hope the season's been good to you. Gosh, we're getting near the end of the year, which isn't a bad thing, right, in 2020? Stay strong. See you next week on The Lionhearted Dentist.